Next, I'll invite Dr. SHARMILA for her talk on management of traumatic glaucoma.
Good morning, everyone. And at the outset, I would like to thank Piyush and AOC for the opportunity. So, for the next few minutes, I'm going to be talking about the management of traumatic glaucoma. We all know that traumatic glaucoma is one of the major causes of blindness. It is important to understand and identify the causes for high intraocular pressure because if you understand the causes, it is easier to choose the appropriate treatment options. So, traumatic glaucoma is due to multiple causes. It could be because of blunt or lacerating trauma, it could be because of a chemical exposure or exposure to radiation. Amongst these, chemical exposure is the predominant cause for glaucoma, which is seen in around 75% risk of glaucoma, followed by lacerating or blunt trauma. The presentation of glaucoma could be early or it could be very late, and it could be reversible or irreversible. So, there are certain predictive factors which influence the development of glaucoma. One is patients with higher age, those who have a lens injury, and those who have a very high intraocular pressure at presentation with presence of hyphema or any excessive pigmentation in the trabecular meshwork. And most importantly, when you notice a patient who have angle recession of more than 180 degrees, then they have likelihood of going in for glaucoma. So, how do we record intraocular pressure in these patients? We all know they are all with acute trauma, so you might not be able to use your apprenation tonometer in all of these patients. So, it is important to identify an area where the cornea is relatively clear, and you can use instruments like an IK tonometer or a tonopin or a diaton tonometer. And sometimes it might not be possible to even use these instruments, so we'll have to just go with our digital or tactile sensation and compare it with the other eye. It is important to compare it with the other eye. You use the other eye as a reference to see if the pressure is low or high. Not always we see patients with trauma having high intraocular pressure. Often we do see patients who have low intraocular pressure. Why do we have low intraocular pressure? Because of inflammation, ciliary shutdown, or it could be because of a cyclodialysis cleft. So gradually, these patients, when you treat the inflammation with steroids, and then when you close the cyclodialysis cleft surgically, then you have an increase in intraocular pressure. So you have dual mechanisms acting, and you'll have to treat them accordingly. So the mechanism of glaucoma could vary according to the type of injury. It could be because of a closed globe injury, open globe injury, or chemical injury. So amongst these, the closed globe injury is the most severe one, and it is often difficult to treat, and it requires definitely a surgical intervention. So what is the mechanism of glaucoma in these closed globe injury? It is mostly because of angle recession or a mechanical damage to the trabecular meshwork. Whereas in open globe injury, there are less chances of trabecular damage. However, it is because of a lens trauma, lens subluxation, or induced uveitis. So here it is because of lens-related mechanisms. So we'll have to tackle the lens. And in chemical injury, the alkali burns are more severe than the acid burns. And how does this lead to glaucoma? It causes shrinkage of the collagen, causing obliteration of the trabecular spaces, and thereby increasing the resistance to aqueous outflow. Or it could be because of inflammation and synechia. So, whatever is the mechanism of glaucoma, your treatment could be either simple if you identify the underlying cause, or it could be really very challenging depending upon the mechanism of damage. By and large, the treatment of traumatic glaucoma is usually by conservative medical management, which we start off with anti-glaucoma medications, steroids, and cycloplegics. Most of this, if it is because of an inflammation, it will subside. If it is because of a lens which is causing a pupillary block with a subluxation, you definitely have to go ahead and do a laser peripheral iridotomy. Or if there is a dislocation either into the anterior chamber or into the vitreous cavity, one has to go for a lens extraction. And if there is a hyphema which is persistent for more than a week with a very high intraocular pressure, you have to go for a AC wash. If none of this is helpful and still the pressures are very high and it is refractory, it was often important to think about a surgical option like trabeculectomy, GDD, or a cyclophotocoagulation. So the medical management has proven to be helpful in around 60 to 80% of patients if it is because of an inflammation. So you generally give more steroids, cycloplegics, and start off with anti-glaucoma medications. However, there are situations where we might have to go for a trabeculectomy. And when you're doing a trabeculectomy, the only tip I would like to give here is you have to use high dose of antimetabolites, unless in otherwise it's contraindicated, especially when there is a scarred conjunctiva or chemical injury induced damage. But I strongly prefer to use a glaucoma drainage device because these eyes have been exposed to trauma. There is a lot of variations which are happening in the conjunctival cytology. There's more chances of fibrosis with trabeculectomy. So I prefer to go for a glaucoma drainage device. And my choice would be to go for an RD with a supramid stenting. And also you can even use an AGV implant. And we have to remember that the conjunctival closure might not be very adequate depending upon the trauma. So one might have to also think about using an autograft from the other eye or use an amniotic membrane graft if there is a deficiency in conjunctival closure. The other newer kid on the block is a micropulse. This micropulse is very good, especially in patients with good vision. So you have an option of reducing the intraocular pressure without causing much of collateral damage, or chances of phthisis or hypotonia are very less with micropulse laser. So I prefer to use a micropulse when there is a very high intraocular pressure and surgery is not needed immediately. So how to treat different clinical scenarios? So we know that angle recession glaucoma is the most common one. And in patients who have hyphema, angle recession is seen in around 71 to 100% of patients. So 7 to 10% of them develop glaucoma over a period of years after the injury. So what is important here is you might not just see that like you treat the patient immediately and then the inflammation comes down, intraocular pressure comes down, and then you forget about the patient. It is important to follow up all these patients annually with the gonioscopy, especially in those patients who have an angle recession of more than 180 degrees at the first visit. Lens subluxation or dislocation, I think it's the most easiest one to treat because you know the culprit is because of the lens, so you tackle it accordingly. So like what you see in this picture, you see that lens subluxation, and it is partly in the anterior chamber and partly in the posterior chamber. So here what you do is it is causing pupillary block. You have to treat it with LPI if there's very high pressure, and then go ahead and remove the cataract and then treat them at the same sitting or later with a secondary intraocular lens. And if there is a dislocated lens in the vitreous cavity, one has to think of doing a pars plana vitrectomy with an SFI. Lens particle glaucoma is also something which is very commonly seen because often there is a damage to the anterior lens capsule. So once there is a damage to the anterior lens capsule, you have a lot of these lens particles coming out, and there is a macrophage response to that, causing very high intraocular pressure. In any case, when there is a prolonged persistent inflammation and it is not getting controlled with steroids or cycloplegics, that should ring a bell saying that probably there's something inside the eye which is still present, and you have to do an imaging to rule out any persistent intraocular foreign body. Hyphema is the most common cause for high intraocular pressure. However, most of the hyphemas will respond with steroids and cycloplegics. Only 5% of them might need a surgical intervention. So when do you take the patients for surgical intervention? When there is an intraocular pressure of more than 50, which is present for more than 5 days, or when there is an intraocular pressure of 45 and more for 1 week, or if there is an intraocular pressure of 35 and above for more than 2 weeks. Hemolytic or Gossack glaucoma is all because of the hemoglobin-filled macrophages or breakdown products of red blood cells that obstructs the trabecular meshwork. Here you do a simple medical treatment, or you might have to think of AC wash, vitrectomy, or trabeculectomy. So orbital hemorrhages are also quite common depending upon the nature of trauma. So you see a red eye like this with a proptosed eye. So there is an intraorbital hemorrhage with extremely high intraocular pressure, causing a compression of the optic nerve, causing relative afferent pupillary defect, drop in the visual acuity. You can see a pale retina and extremely severe pain. In such patients, it's important to get an orbit opinion and go for a lateral canthotomy to relieve the intraocular pressure with or without inferior canthrolysis. So the take-home message here would be, it's important to identify the problem or the cause, and prompt treatment is initiated. Careful monitoring of intraocular pressure, angle status, pupils, disc, and lens status is very important. Treat the underlying cause for high intraocular pressure. Most traumatic glaucomas often require surgical management. However, individualize the treatment based on the mechanism of glaucoma. Thank you for patient hearing.